Hey, Rukia.
Hi, Thomas. How are you?
Good. How are you doing?
Good.
Yes. Oops.
Mm.
Hey, good afternoon, Victoria. Happy Thursday.
Hey Thomas, happy Thursday.
Made it to almost the end of another week. Grab the
One more
slide.
day.
Hopefully. Okay. Let's see. Hey, Andrew's here. Good afternoon, Andrew. Hey, Brian. Hey, Konoshimori. How are you guys doing? Thanks for joining us. We'll get going in a couple minutes. Good afternoon, everybody. I'll wait one more minute and then get going with today's webinar. Okay, welcome everybody to another Thursday webinar series with HiPAM. I'm sure we're going to have a few more trickle in. I believe we have some students from Marguerite's infectious disease class. So welcome to students, and hopefully we'll get more in the next 2 minutes. Let me for our newer members and newer participants, we typically provide a top-down overview in terms of COVID and some science highlights, and then we always do a deeper dive, and that's towards the end of the webinar. So Japan, they started vaccinating Wednesday with their healthcare workers, and hopefully eventually they will get to their other phased populations. But good news in that as their vaccination efforts ramp up, their 7-day case average continues to decrease prior to our holiday season. National overview, we also are mirroring the trend of Japan's cases in terms of our 7-day case average for our nation, well, which is great news. But obviously, with a bunch of states in the South and the Southeast being hit by severe winter conditions, the vaccine distribution will be affected, as well as potentially maybe transmission in terms of people being forced to stay inside again. So we will see how that plays out in the next couple of weeks. Added this new slide in just because we're getting more and more visibility and reports on variants within our country. So CDC updates this. I'm not sure how often, but we will be providing this as a new slide on our Thursday meetings in terms of our variants. So the B117 is a UK strain, B1351 is a South African, and P1 I believe is the Brazil strain. So you can see Hawaii still within that 1 to 100 for I believe the UK strain. Moving on to our state level overview, Arizona, California continuing to overall trend down, which is great as we are starting to hear more and more about potential programs or for travel for our vaccinated individuals. And so these states, Arizona, California, and the other two in the next slide account for a lot of our travel as well as our returning residents. Same trends, Nevada and Texas. Great news, continuing to trend down. Texas is getting hit hard by the snow. So once again, keeping an eye out in that state. Moving on to our Hawaii specific overview, continuing to trend down for all of our counties, for our cases per 100,000, as well as our percent positivity. And for our newer members, you can always get this information on HiPAM.org. It's updated on a daily basis throughout the work week. We're still at phase 1 Bravo for state of Hawaii vaccination effort, continuing to increase our cumulative doses, increased by over 6,400. Once again, with some clarity provided by Dr. Josh Quint from DocD last week. You know, there is some data lag varying from provider to provider and also facility to facility, but you know, that's why it's always good to look at the graph per week in terms of vaccines administered. And you can see that our second dose, those who are fully vaccinated, our population is increasing on a week-to-week basis. Percent population 75 and older continues to increase, which is great. Those are highest risk. And our distribution progress overall continues to be at a high percentage. So once again, great news for our state effort for vaccination administration. Testing turnaround time, one of the major pillars for keeping our case counts low, in addition to you know, overall testing capacity, contact tracing, and isolation quarantine. So this is a great metric that we always pull up every week, and we've been holding steady since we've gotten this data. For our Hawaii specific forecast, you can see that our red is our pessimistic per se, and even then with the data points that we've been looking at from partners at DOH, as well as travel and just overall vaccine uptake, we are projecting a even decreasing trend for our pessimistic and a slightly decreased trend for our expected cases for the next 14 days. And then as a result, our hospitalizations, ICUs, and fatalities will mirror what we're forecasting for our 14-day case forecast. And then this here just illustrates in a numerical format, once again, what the previous slide is showing. So only two science highlights today. You know, there's always a bunch to pull from, but I wanted to spend a lot of time today on our webinar, on our deeper dive, and hopefully field a bunch of questions and answers from our attendees. We've been focusing a lot on vaccines and the variants, but taking a step back and looking at from a more public health holistic perspective, I did want to bring up a report from the CDC that came out yesterday or the day before in terms of life expectancy impact due to COVID from last year. And then some good news, more funding for variants and identification of variants. So this is from NPR. You can go to the link prior on the slide prior. I couldn't find the actual report from the CDC, but I know it's there. You can see from these two graphs that life expectancy from this study declined, and our ethnic populations have been hit a little harder. Our Hispanic and African American populations have seen a larger decrease in their life expectancy on the graph to the left, and then especially males, Black and Hispanic males, face the largest decrease in life expectancy. And then normal limitations are good in terms of decreasing the impact, but for this particular study, they expect that due to the limitations of this study, the impact might be even greater than what they found. So once again, as we still focus on the vaccine effort, there's an overall larger public health effort that we need to continue to focus on as a state and as a country to deal with all the secondary and tertiary impacts, the mental health impacts, the access to regular care, food inequities that are continuing to be impacted by the fallout of shutting down and the pandemic. And then, everybody's aware that we do have some of the variants circulating in Hawaii. And so funding has been increased by the federal government. And then I wanted to also tie this into the new slide that we will be adding to our weekly Thursday series that I featured previously, that is now tracking variants by state. And then as we get more fidelity for Hawaii, we will continue to provide further guidance on that. For our newer participants, if you do have questions at any time, please feel free to drop them in the Q&A section, and I'll be sure to recognize that and bring it up as we go through. But as I am looking, there are no current questions or comments at this time. I'm going to go ahead and as we draw close to about a year in terms of COVID in Hawaii, that means that we're coming up on our 1-year anniversary in terms of HiPAM, and I thought that now was a prudent time in discussion with the rest of the core members to do a look back on the history of HiPAM and the work that we have produced together in support of local and state efforts. So if you haven't had a chance to take a look at our website, a lot of this language is mirrored on our website, but basically in April 2020, Dr. Victoria Fan and a bunch of concerned researchers and scientists within Hawaii got together through Uhari listserv and word of mouth networking and the Coconut Wireless in Hawaii to try to get further information from the Department of Health in terms of just basic case information, where it's located, etc., just to inform some of their own specific modeling efforts. And then as a result, HiPAM was organically formed on a volunteer capacity, tapping into the individual expertise and professional expertise for all of the members that made up of the core HiPAM member at that time. And every single member was and is still currently motivated, as residents in the state of Hawaii, whether it be Oahu or other islands, to really do our best to minimize the disruptions and to maximize the health and economic benefits of pending policy decisions based on the response to COVID as it was transpiring on a day-to-day and week-to-week basis. And then we're a group of applied epidemiologists, data scientists, health workers, professionals in multiple sectors across the state and local footprint. So here is just some of many of our partners. Obviously, we have a lot of great representation and participation from DOH, specifically BHH Surge, Disease Outbreak Control Division, strong support from the beginning from Hawaii Data Collaborative and PHAC. HHIE, Francis, I'm not sure if you're on, but thank you for being part of from the beginning. I see you on. Thank you, Francis. And then obviously UH Manoa, Maui College, Uhiro, more recently, but glad to have Uhiro on, HMSA, Queens, and we've all really just come together to produce multiple products and to really be a space to talk shop in terms of modeling specifics and COVID transmission dynamics. So why did we need HiPAM and why do we still need HiPAM? Well, COVID-19 was the immediate driving force behind the this organic growth of HiPAM, and then moving forward in the future, future health and infectious disease monitoring and modeling, and then also the role of the university here in advising and supporting public health efforts and working with our state partners, and also providing a multidisciplinary research. It's not just epidemiology. We have data scientists, we have astronomers, we have mathematicians, we have health economists. It runs the gamut. And once again, combination of state, county, and local collaboration and insight. So, it's really hard to provide a timeline, but I figured, this epi curve provide some context, and then wanted to throw on, I feel like it's been so long since we read the news, when that first case of COVID really hit the state. So just to provide some context, this is the epi curve. And then, for the timeline of HiPAM, when COVID first hit, there was no Hawaii specific model that was driven locally by any local researcher that we were aware of. I think at the time when it was really growing in interest, the IHME model by University of Washington was the only one that provided any state specific modeling. And there were issues that we previously discussed with that and how their model inferred and applied to Hawaii. And so you can look, April 7th, HiPAM was founded, and that was kind of at the peak of that first wave. And then kind of a backstory, I was brought on to be the lead forecaster modeler for COVID for ESF8 within HiEMA. So working in parallel and collaboration with HiPAM and DOH, we kind of were working the operational modeling piece as well as the theoretical and trying to find that best fit model for Hawaii moving forward. A large part of the initial effort from HiPAM was just to access better case data to better inform assumptions. And at that time, all of the core members were working on their individual models. And I'll kind of highlight some of the work later on, but I know Itzvan was very interested in super spreaders and focusing his model on that. And Monique came in later to focus on some other efforts. And then as we kind of moved through this dead period, let me bring that pointer up, from about May to June or so, it was relatively flat. But at that point, there were questions, what would it look like if we were to start to open up travel again? And really during this point in time, it was still efforts within ESF8 with myself and help from Bobby with the support of BHS Surge to really start to address some of those scenario-based questions, and also still creating a 14-day forecast and flying the plane or building the plane as we fly it. And then beginning of July, there was an official handoff of forecasting responsibilities from ESF8 to HiPAM, and from then on till now, HiPAM has been supporting the state effort in terms of providing that front-facing 14-day forecast through HiEMA. And then also there was a lot of work put in by HiPAM in collaboration with PHAC and BHS Surge to produce this prototype COVID-19 dashboard, and that was in the height of this second surge. So moving on to the fun parts of the model itself and how the model evolved. I'm not going to get so much into the specifics, but you can see that this particular model really was not developed by anybody within HiPAM. This was open source on GitHub. Once again, going back to this timeline, I was brought on early April. There was nothing built, and there was a request at this particular time and point by Director Hara to ask, are we truly going to need to stand up the convention center as an overflow ICU capability? And when I was brought on, I had, I think, 24 hours with the rest of the ESF8 team, Dr. Hankins et al., to answer that question, and obviously no time to stand up any type of model on our own. So we started with this initial epi calculator, and it's based on the standard SCIR model. The reason why this was chosen above some of the others was that it allowed to adjust the R0 or the infectiousness of the disease at a singular time point. So strengths, ready-made tool, easy to manipulate, pretty straightforward data visualizations. Limitations, you can see it's not truly realistic. It's really based on a theoretical spread of COVID, and not meant to deal with a lot of the operational and the realistic situational impacts. And then call out, I'm not sure if Bobby's, huge call out to Bobby, who really helped the initial effort for the refinement of the HTML version of the file. So the next steps was to take the limitation, work on this strong limitation of one change in the R0 to multiple changes in the R0 over time, right? It makes sense as people adjust their behavior, as policies continue to be implemented, how would that look like? And with this particular model, there's no way to help policymakers and also those working in the field directly to understand possible scenarios. So that was the first ask that Bobby and I were working on, and as well as to improve data visualization. Obviously, it is still relatively crude, but an improvement, and remembering that with the stresses and the pressures of working in an operational environment, that was a huge factor in terms of the quality of the product that we were able to put out in a very short time frame. Also, with this HTML version, with huge assistance from BHA and ADAD and the SCO, State Epidemiologic Working Group, we also tried to help educate policymakers. This was, I think, our first product where we were just trying to show how differences in transmission dynamics in what an R0, how to change the R0 would look like. And this was our first effort in scenario-based modeling and education. And you can just see how the hospitalizations would be impacted based on changes on the R0. And once again, this is really when we, back in late April, when the R0 was still trying to be established based on researchers. We really didn't know much. And this was only 2 to 3 months into the whole COVID response. And then moving on to May, when, due to the shutdown in Hawaii in terms of travel, our cases really flattened out. And therefore conversation was starting to bubble in terms of, okay, what would, when is the right time to reopen travel? And therefore, that's another huge crinkle into the modeling. How do we account for new cases, whether they be returning residents or tourists? How do we account for them potentially being a positive case coming into the state and impacting our very flat, our day-to-day 7-day case average? So once again, and in full disclosure, I am not, a huge infectious disease modeler. I'm an epidemiologist, kind of brought in to guide a lot of the data synthesis, and therefore we're still working with Bobby to try to find the best way to further refine our model. So this model is from, and I'm blanking out right now, the University of Basel, who was the only model at the time that tried to factor in how imports per day or how imported cases would impact current disease transmission. And another strength of this particular model was that, at this point in time, we had a slightly better understanding of COVID case and hospitalization impacts based on age stratification. So we were able to further refine some of the assumptions of the model based on these age-specific parameters as well. And then understanding that the R0 fluctuates on a day-to-day and a weekly basis, this particular model provided a confidence interval per se in terms of the R0 and the bandwidth in terms of what would be projected within the left and right limits of the average R0 for a particular location. And then the big limitation to using this University of Basel model was that I had to run on a daily basis case projections, and the limitation to that was it wouldn't take into account historical fluctuations in hospitalizations and cases and fatalities. So once again, dealt with another hurdle, trying to troubleshoot that and problem solve operationally what was quite difficult. So working with Applied Research Labs, Margot Edwards and her team, Basim, to develop, to further refine and take from the University of Basel code to create not a dashboard, but a working tool that allowed us to further manipulate and to use data visualization. And this was the first time we took our projections and was put onto the HiPAM common operating picture. And here's an example of what it would look like on a day-to-day basis. It looks similar to the HTML file, but now it was something that we could use on a day-to-day basis without a lot of effort. The first step in automation per se. And then wanted to do a call out once again to ARL featured in UH News in terms of collaboration from the academic side into the operational side. And then with that handoff in the beginning of July from ESF8 to HiPAM. So this was the initial HiPAM model. It was JavaScript with the ARL tool. There was no live feed. And then so that was what I kind of handed off to HiPAM and Levi and Bobby when I went to Texas for training. And with a lot of hard work between Levi, Bobby, Yosh, and all of our partners, the current HiPAM model now utilizes Python, which is a lot easier to automate on a daily basis. The G2, the Epi calculator, the Basel model, improved compartmental flow, and then it lives outside on the cloud, and it all feeds in to what you see on our Thursday meetings and also on a day-to-day basis on our HiPAM.org website. I'm probably not doing the great work that Bobby and Levi and Victoria and the rest of the team did, but there were a lot of work. There was a lot of deconfliction that went into the simplest of things, such as defining what is an active case, based on the data that was available, and really how that impacted the model that you see, and also where we get the data, the timing, and accounting for lag. So a lot of back-end work that is not visible, that is going into what you see today. And once again, we are currently working on refining it even further, and we'll provide an update once we are ready to roll that out. So for our new participants, once again, this is what it looks like on our website. This is what is shown and pulled on the common operating picture for the state of Hawaii. And then once again, these other gray bars are our attempt to bring together the CDC ensemble and to show where our model falls within the CDC ensemble for the state of Hawaii. And once again, this looks very familiar because we pulled this for our Thursday webinar series, but this is always here on our website for your ease of use. And this is one of the things we don't use. I think is very helpful, but we're still trying to refine it. But this was a great effort by Levi in terms of trying to visualize a bunch of different data points, specifically for the county of Oahu, Honolulu County, for their reopening metrics, and finding a way to easily visualize based on the metrics that the mayor decided to use for their reopening strategy. And so you have your 7-day case average on the left, your 7-day average positivity, understanding those are two metrics that are needed to reopen. And then you have your week-to-week timeline, and then trying to show 2 straight weeks of being at the lower threshold in order to move to the next higher tier. So this is there. We choose not to call it out every Thursday, but if you're a data geek, it definitely will make sense to you. Additionally, let me go back. So additionally, we have just another way to explain more of the epi terms that feed into our model. And if you go to our website, if you just roll over it, if you put your cursor over any one of these square definitions, it's going to flip, and you'll actually see definitions incorporating some of the epi and the scientific terms to better understand our model, but also just very universal epi concepts that will increase one's awareness when listening to all things COVID and potentially other infectious diseases down the line. Moving on to what's next for HiPAM. We'll continue to provide a 14-day forecast to support the state. We have continued to field and support scenario-based questions by our community partners, and our work to further establish HiPAM as a trusted partner on COVID-19 and unfortunately potentially other infectious diseases down the line. And once again, to serve as a multidisciplinary resource, not just on the modeling itself, but the other impacts, the mental health impacts, modeling some of the other behavioral impacts, as well as economic impacts as well. Once again, you can join us at our community meetings. Just really want to highlight the fact that this is a group of people who really care about the state and our local community. And then just the next few slides are going to highlight the great work by all of our HiPAM partners, and it's been featured a lot in our local and sometimes national media. There was a huge product put together that I called out previously on this data dashboard that HiPAM helped put together with PHAC and BHS Surge, and that led to the current iteration of the dashboard that you see on BHS, DOH BHS website today. And then this is just some of a lot of the great work by our core members. So I mentioned Itzvan. I'm not sure if he's on today, but he published a paper on super spreaders. Monique and her team. And then I believe Lee submitted testimony. So, it's not just working in academia, but really working directly with community, with our policymakers to get the information out so that it's understood by decision makers and also our public and concerned public. And for a full list of all of the work that we've done in the community, you can go to our opinion page below to see all how we've interfaced with community and policymakers. The other thing I wanted to call out is, we've as we continue to grow and get more, increase our footprint, we are also trying to increase our educational footprint in terms of, reaching out to our students, and helping them understand infectious disease modeling, some of the basics, some of the coding, but also tying it in terms of larger workforce development. COVID isn't going anywhere anytime soon, and trying to create a bigger pool of experts and growing experts from our students to position our state and our counties to respond faster, and to create a deeper pool of experts moving forward. So if you are interested, in terms of if you're a professor or instructor, or if you're working whatever industry you work with, and you want your colleagues to better understand just anything COVID or COVID transmission or modeling, we are resourcing. I know that we all would love to share the knowledge that we have with the rest of the community. So I just want to call out that Levi, Bobby, Victoria recently did a guest lecture, as well as I believe Tom the following week to Marguerite's class. Once again, these Thursday meetings are meant to be a standing way for us to interface and field questions and to share the most up-to-date news and topics for COVID and for COVID vaccinations with the community, but with a larger goal of increasing data literacy and the analytic capacity within our state and community. But the biggest thing is we're here to serve you. Once again, going back to why HiPAM was started, it was just organic, because we all cared about what was and what is currently going on with regards to COVID and all the relevant impacts within all of the health realms for COVID, and what we can do to support as researchers and concerned professionals. With that, Victoria, I hand off to you if you have any other comments as the chair of this great group.
Hey, Thomas, I wasn't expecting to talk, but I think you did a really fantastic summary here. The one thing I'll just add is that, I think early on we turned in about 2 or 3 formal data requests. And that was initially what HiPAM sort of focused on and rallied around, and then sort of transitioned into formal forecasting and the website, and all of HiPAM's work is really the collective success of all of the members and everyone's just incredible participation from the beginning. Meeting 8 o'clock at night. I think we met, quite late on some evenings early on in April, and just incredible dedication. It's just been a really wonderful community, getting to know so many different faculty in computer science, biology, math. So we really hope moving forward, HiPAM will continue to have relevance and impact and importance here in the state. And again, none of it would be possible without all of you. I think the collective wisdom and knowledge that this group has had, I think, is just a really inspirational story. I think realizing that no one person can beat COVID, but I think this brain trust of incredibly smart, thoughtful, and very kind people who really want to serve and benefit Hawaii is, I think, a really great success story. And I don't think other states necessarily have had a HiPAM. So I just want to say I'm really honored and feel very privileged to have gotten to know all of you over the past year. And I really can't believe almost a year has passed. So we're looking forward to continuing to work together, unfortunately, while COVID is still here. But I think that the need for pandemic preparedness will continue for a long time. And in my pandemic paper with Larry Summers and Dean Jameson, it is a unpredictable, but nevertheless expected event. And so it's just only a matter of time when yet another pandemic hits. So with that, I'm going to pass it back to Thomas. Thank you.
Thank you so much, Victoria. Thanks, Monique, for your kind comments. Yeah, agreed. I think the great thing is this situation brought together a group of professionals, researchers, academics that normally might not have come together. But the nice part is, hopefully we'll find a very good solution set to COVID, and then we can take this great brain trust and partnerships and start to move to other huge public health and huge just regular public issues and use science and math and our expertise to address them. So I want to make sure I leave time for any other questions, comments. I apologize that it wasn't a very long brief, but I figured it was much needed to add some context and as a positive reminder at how far we've come within a short amount of time, even though it feels like we've been in this COVID quicksand quagmire for quite a while. And once again, I'm grateful we have, Dr. Berryman, Dr. Quint from DOH, which is huge. Once again, HDC, HHIE, all of our partners, HMSA, Queens, and that speaks to the collaboration. Oftentimes you'll just find researchers together or UH academics, and sometimes not working with state partners and also private industry. I think this was a truly multilateral approach to solve a singular issue, which is really hard to find, like Victoria said. So I just want to say thank you again to everybody who's our core members, and also everybody who participates and takes what we put out and to share that with the rest of the community. So I'll stand by for about a minute, and then if not, I'm sure the best part of this is that I'll hand back some time to you to go about with the rest of your Thursday. Okay, I guess everybody wants to start their happy hour early this Thursday. So I will conclude today's Thursday webinar. Marguerite, I will hop onto your Zoom link and meet with your students right after this. So I'll see you soon. But thank you everybody for your participation again, and see you next week, Thursday. Take care and aloha.